Hi, I'm Christina Cusimano, Senior Vice President of Marketing at AGS Health, and I'm here today with Ryan Chapin, who's our Executive Director of Solutions, and we're here today to talk about patient access centralization. Thank you, Ryan, and welcome.
Thanks for having me.
Really appreciate having you here and look forward to our conversation today.
As do I.
So Ryan, could you begin by explaining to our audience what exactly a centralized patient access model entails in a healthcare setting, and what are the core functions that typically fall under this centralized umbrella?
So, good question. Think about, centralized patient access as taking those core functions that you would normally find in the clinic setting, right? Benefit and eligibility checks, prior authorization, scheduling, and taking those out from the clinic setting and bringing them into a centralized function, whether that's virtual or brick and mortar. And generally the drive to do this by providers can be growth, can be inconsistent processes around those patient access functions, as there are many benefits that we'll get into in our discussion, right? I mean, anytime you walk into a clinic to see your provider, right? Whether you're at a hospital or you're at an outpatient clinic, you are walking in and you are greeted by someone, and that person not only has their role is to greet the patient, probably discharge them or talk to them about potential financial responsibility, but over the years their responsibilities have continued to grow, and the complexity of those responsibilities has also grown because of payer requirements and things like that. So what we're seeing is there's a drive to take a lot of those core functions. So you ask which functions. You have benefit and eligibility checks, patient estimates, prior authorization, scheduling. Those may be done by someone in the clinic. And more frequently now, if it makes sense for the providers, they're pulling those functions out into centralized teams that are specialized in each of those individual functions. We'll get into this, but think about efficiency gaining. Generally, these clinic settings are high turnover, so when you have that centralized and specialized team, there's ideally less turnover, easier to train and retrain and update content. That ultimately should lead to less denials and a better experience for the patient when they do come into the clinic. They have more attentive and responsive staff members that they're talking to.
So Ryan, in your experience, what are the most significant ways that centralizing patient access operations can positively impact a healthcare organization's revenue cycle management? Can you provide some specific examples of and or metrics of what that looks like?
So I think, and there's a lot of reasons why a provider may want to centralize, and it may not honestly be the right move for everyone. But as we've seen, a lot of AGS customers and folks that we work with, they are in a continual growth stage, right? And they may be growing through M&A and acquisition, and they're acquiring all these separate and disparate workflows that somehow need to work together in one piece. So primarily when you think about the benefits of centralizing patient access, it really comes down to two major things. One is the patient experience, because the patients ultimately should be the ones that are benefiting from it, from those, the rewards of the centralized teams, right? If you pull out those functions into centralized teams, the person that you're interacting with at the clinic as a patient is more focused on you and what you need and making sure that you're ready for your visit. And when you are leaving the clinic setting, that you are prepared for whatever those follow-up steps may be. And they're not maybe distracted by making sure that prior authorizations are done or checking, one last time the benefits verification of people coming in the next day. I would say second is denials. Ultimately, so the patient comes first, and then it's really denials and the financial impact of why people and why providers want to centralize is, I think generally half of denials can stem or likely stem from front-end processes and process breakdowns and inefficient workflows, not using technology efficiently. We can go on and on. So if you bring those teams together, you centralize them, and they have standard workflows, and they're utilizing technology to the fullest, ideally your denials go down. And with that, so many other things cascade as well, right? If you are getting claims out the door more cleanly in the first place, there aren't denials, then that then require a back-end team to rework. So there's a major opportunity cost of the reduction in denials in addition to accelerated cash and increased revenue. I would say those are the two big reasons behind centralization.
Yep, that's great. So Ryan, that's all really interesting. So tell us about some of the common pain points or inefficiencies that healthcare organizations often experience with decentralized patient access models that centralization aims to address and achieve.
Yeah, so again, in the decentralized models, what you're seeing is, right, again, just I'll use the same example. You walk into the clinic, there's maybe one or two folks behind the desk, they're talking to you, but they also have maybe 10 other workflows or functions that they are responsible for doing throughout the day, all of which are critically important to securing you and your financial stability really before your visit. So what that is primarily, right, is a massive administrative burden on the staff, right, which can cause a lot of burnout. It's already a high turnover position. What you also have is, and there has been movement in the right direction here, which I'll get to in a second, but over the past 10 to 15 years, you have seen payers, as we're moving more towards value-based care, requiring much more proof and documentation for prior authorizations, and the number of services that are requiring prior authorizations has grown. Now, recently, over the last year and a half, there's been a movement in the other way where payers are requiring less services to have a prior authorization, which is great, and I think we're starting to see a trend go in that direction. But by and large, there's been a massive influx in complexity of the prior authorization requirements, as well as the services requiring prior authorizations. I think just kind of macro economic trends, right? Labor is expensive. It's continued to be expensive coming out of COVID. And in general, it's, these clinic settings are high turnover and high burnout, and all of these factors kind of compound on themselves. So you add the complexity plus an already stressed labor market, and it's just kind of this perfect storm of, with these decentralized patient access centers, that it just puts a lot of pressure and ultimately leads to a poor patient experience and higher denials. I think two others, right, within those decentralized patient access models, you have, and if there's also like M&A going on, you can have a lot of different workflows and processes or standard operating procedures, whatever you want to call. So what's the workflow at one clinic may be completely separate at the other, and which may not be a big deal, but let's multiply that by 50 different locations, or maybe you have, over the past couple of years, your provider group has acquired 3 new segments or 3 other smaller providers. That's a lot of different workflows and inefficiencies and potential human error that, again, ultimately results in potential for higher denials.
And are there technology gaps as well?
That's a good question, because the payers will always, or at least have until now, have always been ahead of the providers in the tech space. So what we see is providers, they have larger margins than our payers have larger margins than our providers do. So they're able to invest more in technology, and what that technology is doing today is they're able to identify discrepancies in workflows, or rather in prior authorizations, and they can quickly identify if more documentation or more proof of medical necessity is required, faster than our providers can actually submit prior authorization requests or information. So they are using technology more effectively than the providers are today. So what I think providers need to think about is, there are a lot of prior auth technology vendors out there, and they all offer somewhat different, it's this specialty or this payer that they kind of specialize in from a prior auth automation perspective. So what I would caution is, or recommend, is that providers just kind of pick the right technology for them and make sure that it works, and know that it won't be a solve-all, and there's going to be a human in the loop that's required in almost all prior auth tech.
That's great advice.
Yeah.
So Ryan, for hospitals and health systems considering a move towards centralization, like what are the first few crucial steps they should take in the planning process?
Yeah, so obviously assuming that there's buy-in and organizational, alignment to move towards a centralized model, the first thing that a provider should look to do is standardize their processes. So go take inventory, take current state, what is happening across your patient access centers today and those functions you want to centralize, and standardize those processes, right? So make sure that everyone is reading from the same playbook, the same workflows or SOPs. Set up KPIs, baseline your performance. Understand how the teams are performing today, because this will be ideally a proof point to the success of the centralized team, and you'll want to be able to show that to your leaders. And if you're considering a proof of concept versus what we would kind of consider a big bang rollout of a centralized team, those data points will help get buy-in from the rest of the team. So first thing, again, centralize your processes, put KPIs, baseline your performance. After you centralize, you at this point you can consider leveraging technology, investing in technology, understanding where you have technology gaps, and finding where those gaps can be filled with partners or vendors, or through, maybe if you're an Epic shop, you're underutilizing some of the functions today. So at this point in the process, you can start to look towards what technology you want in this future state of your centralized model. Then the next step is to actually do the centralization, right? So whether that is brick and mortar or it's virtual, that's a major consideration. Are you leveraging a brand new team, or are you pulling folks out of the clinical space? You want to figure out your delivery model for who is actually going to do the work and where are they going to do the work from. So a major decision point here for providers is exactly that. And that decision should involve whether or not we are in a space to leverage an offshore vendor, like someone like AGS, right? So what we see a lot of times is folks will come talk to us and they say, hey, we are on the maturity path to a centralized patient access team. How can AGS help? We're thinking of a hybrid offshore-onshore team. So that's something that providers will want to consider as well. The third is, assuming that you've done you've standardized your processes, maybe you've infused some tech, you've centralized the team, they know who's doing it, where they're doing it from, and you've kind of reached ideally this plateau of performance where you're doing well, you're tracking your KPIs. This is when you want to start optimizing, right? So you leverage those KPIs, you re-baseline and you figure out where are those areas of opportunity to make our processes even better and to fine-tune the technology, ideally that you've implemented or have been considering implementing. Maybe they can get you to that next level of performance. So this optimization point is really great, and it's not a journey with an end. It's a continuous journey, right? So you don't want to, be done, sit back and relax once you've standardized and centralized. You want to continuously look for improvements in this optimization stage. As part of that is you continue to look at your KPIs and your metrics, and ideally you're comparing against your peers, and continuing to understand how you can improve your metrics.
I always say it's not a destination, it's a journey.
Right. And centralizing patient access is exactly that, especially for those providers that are continuing to grow, continuing to acquire and be inquisitive. You'll need to create kind of those playbooks. How do you bring in those new functions? Or if your centralization strategy started with radiology and you want to expand to surgery, what does that playbook look like? And how do you get buy-in to achieve those goals of broader centralization?
That's great advice, Ryan. So Ryan, you mentioned technology. So what are some of the essential technologies or systems that are typically leveraged in a centralized patient access environment to enhance efficiency and accuracy?
Yeah, it's a good question, because there's a lot of technology that's available on the front end, and like many rev cycle technologies or just rev cycle functions, the tech is constantly changing and evolving. But there are some entrenched technologies that I would imagine most providers today are leveraging, and if they're not, they should be. And maybe if they're not, they're more in that emerging market space that usually runs a couple of years behind other maybe more mature providers like your IDNs, right? And that's primarily right scheduling technology. There's Even though scheduling technology has been around for quite a while, the advancements in the technology itself are pretty cool. So there are. We were at a conference recently, and folks were talking about those advancements. And think of if you and I have both scheduled a visit at a clinic that's 20 miles away. You live 5 miles away, or you live, let's just say 1 mile away, and I live 20 miles away. The models that these guys built showed that you have a higher cancellation rate because you are so close and it's convenient for you to miss your appointment and reschedule. Whereas for me, I've made a commitment to drive 20 miles, which maybe could be an hour in traffic. So I have a less likelihood to cancel my appointment. So the scheduling technology is not just a scheduling platform now. There's also predictive analytics to say, what is the probability that Christina is going to cancel her appointment, and we need to fill that slot so we don't lose out on a revenue making hour, versus the probability that I will cancel my appointment. So there's really cool advancements in scheduling technology that take predictive modeling. So it's an entrenched technology that's being brought to the next level as we move into this AGI or agentic AI kind of space. Real-time estimate and or real-time estimate for benefits and eligibility verification, as well as patient financial responsibility, those are entrenched as well. And similar to scheduling, you now have, as these new agentic AI and machine learning models get more entrenched into our RCM technology, those are also, similar to scheduling, how we talked about propensity to show up for your visit. There's also great, we can pull an estimate, right? There are bots that go scrape payer websites and they pull an estimate based on the service, your payer, and your plan, right? Similarly, we have the technology that will say, hey, what's the likelihood that Ryan and Christina will both pay pre-service, and then what is the chance or the probability of collections? How does that degrade if we don't collect up front? So it's, again, taking those entrenched technologies and they're being brought to the next level. I think the most exciting and most promising of the patient access technologies in my mind is prior auth, because I think it's mature enough right now to be valuable to providers if leveraged right, but it is immature enough that there is not a clear-cut solution in the space, or an automation solution in prior auth that can kind of do everything and do it well. So for instance, AGS, we have our intelligent authorization tool. It works extremely well for radiology authorizations, and then for surgery, PTOT, and therapy and infusions, there are parts of the process that can be automated. So that's our technology. And then you look at some of our competitors, or even clearinghouses and your Waystars of the world. They have technology as well, and a lot of the times they are serving a niche specialty, or maybe for just a payer. The thing I would caution with the prior authorization tech is just finding the one that works right for your care setting, your payer mix, your specialty mix, right? Because there are so many different vendors in the space, and they all kind of operate in their own little silo today. But we'll look to see that change dramatically over the next couple of years, which is very exciting, because it's right. The prior authorization process has grown in complexity and scope, which has challenged a lot of provider groups today.
So Ryan, for healthcare leaders who are on the fence about centralizing their patient access operations, what would be your key piece of advice or a compelling reason for them to seriously consider this strategic shift?
Yeah, well, great question. I think a few things come to my mind. One is, is there some organizational appetite to move to a more centralized model, assuming that if you're considering this, you're in a or decentralized or partially centralized. Two, do you have a lot of denials that can be routed, or that are routing from the front end? Are there systemic issues within your patient access teams that are decentralized? And three would be, do you have a lot of high turnover and attrition in those roles where your patient access functions are today, right? So I think those would be My three main points, obviously, I think a fourth would be, along with that organizational appetite, like, is there a bit of investment that is available to create a centralized team?
Well, great information, Ryan. Thank you so much for joining us today and shedding some light on patient access centralization. Very, very insightful. Thank you very much.
Thanks for having me.